My talk will be about the clinical aspects of the sperm DNA fragmentation. In this presentation, we'll talk about the background of the sperm fragmentation, and we will talk about the causes, the lab diagnosis, the management, and the debates. There is a lot of debates about this subject, and the recommendation for such to get over these debates. We know that the sperm chromatin structure during later stages of spermatogenesis, nuclear compaction occurs to protect the DNA against stresses, especially oxidative stresses that will face the sperm during its journey from the epididymis till the oocyte. The mechanism by which the spermatin is condensed is the histones are replaced by protamines, and DNA is wrapped around the protamines, and then the disulfide bonds between the protamines condense and stabilizes the DNA. Improper condensation or failure of condensation will eventually lead to sperm DNA breaks, and this we call it sperm DNA fragmentation, or we will refer to as SDF. There are two types of breaks, either single-stranded breaks or double-stranded breaks. Unfortunately, the oocytes and the embryos can repair sperm DNA damage, but not the double-stranded breaks are difficult to repair, but usually a number of repairs can be done inside the oocytes or the embryos. What causes the sperm DNA fragmentation? It might be intrinsic during spermatogenesis, or extrinsic, we call it post-testicular causes. This remolding problems during spermatogenesis or protamine deficiency or abortive apoptosis, this will lead to the SDF. And intrinsic cause, a lot of things which we are familiar with in andrology. Cigarette smoking is the one, and the obesity, aging, genital tract infection, varicocele, chemotherapy, heat exposure, alcohol abuse, and there are other things. All this acts through producing excess reactive oxygen species, and this will lead to the DNA damage. The biological effects of the DNA damage depends about the amount of the damage and the capacity of the oocytes and the embryo to repair the damage. There is a possible relationship between DNA damage and impaired implantation, abortions and miscarriages, and genetic diseases in the offsprings. However, there is a little or no effect on fertilization. Usually, the sperm with DNA damage are able to fertilize the oocytes. And the oocyte then either repairs the DNA damage or it fails to repair the DNA damage, so it will lead to impaired implantation, the other pathological effects. Assessment of sperm chromatin structure or sperm DNA fragmentation. You have a lot of tests. Some of them are dependent on using nuclear dyes, and some are automated, the glutanil, the COMET, and the sperm chromatin structure assay, and other tests like the sperm chromatin, the dispersion test, or the halo test. These tests should be performed. This is very important to tell you that it should be performed after not more than 48-hour abstinence. Usually, when we do a semen analysis, we ask the patient to abstain for 3 to 5 days or even 1 week. If you do a sperm DNA fragmentation after a long abstinence, this will affect the results, will increase the sperm DNA damage. So we have to make sure that the patient will get the sample after 1 day or maximum 2 days of abstinence. The commonly used sperm DNA tests are the COMET test, which is the special treatment that remove the nuclear proteins and then allow double-stranded DNA to unwind, and we assess the DNA fragmentation by single gel electrophoresis and fluorescent microscopy. I want to come back. Okay. This is our normal sperms, and these sperms with DNA fragmentation, the fragmented DNA will move in the electric field towards one of the electrodes and will give us this characteristic COMET, and that's why we call it the COMET test. And the one behind is the tunnel test. It's that this assay relies on detecting DNA stranded breaks directly by labeling them with fluorescent dyes that will go a flow cytometry and will get curves. This is a positive tunnel test, and this is a negative tunnel test, and you can estimate the number of sperms with DNA fragmentation. There are the other commonly used sperm DNA fragmentation test is the sperm chromatin structural assay. This is a fluorocytometric version of Archidine orange. This is the sperms with DNA fragmentation, and the green sperms are the normal sperms. And this is the third or fourth one, which is common. It's the sperm chromatin dispersion. This does not measure directly the sperm with DNA fragmentation, but it in this test we measure the stability of the DNA to be for acid denaturation, and then we give some sort of dyes. This normal sperms will have this figure, and abnormal sperms or sperms with DNA fragmentation will be seen like this. There are advantages and disadvantages of these tests. We will not go through them because they are a little bit laborious. But the halo test, which is the one most used in most of the lab because it's commercially available and it's a simple test, but it has an intra-observer variability, and it's does not measure directly the sperm with DNA fragments. It measures the susceptibility of the sperm to DNA damage. Both are related together, but not 100%. Other tests are more objective and more sensitive and reproducible and reliable, but usually they are more expensive and they need specialized training and specialized instrument equipment like flow cytometer or fluorescent microscopy. And that's why they are a little bit expensive than the other one. Not a little bit, a lot of expensive. I'm sorry. The DNA fragmentation index is the number of sperms على total number of sperm tested times 100. It's an index percent. 20% threshold level has been suggested as a cutoff value to discriminate infertile from infertile men. Usually this sharp definition, if a patient has a 21 DNA fragmentation, we tell him you are not going to conceive, and if he has 19, we'll give him okay. I don't like personally, and a lot of you will agree with me, that should we have a cutoff levels, they're not precisely. And these values have not been clearly established, but from a perspective point of view, if you had less than 15% DNA fragmentation, you have a good fertility potential. If you have 15 to 25 is an average. If it's a borderline between 25 and 30, more than 30 is a poor fertility. If we got a patient with a 70 or 80, this is very, and we should compare the actual level and don't depend on a single reading. You have to repeat the test because it is very liable to change from one time to another. There is other method has been developed as a surrogate to test the sperm DNA fragmentation is to measure the oxidative stress in the seminal plasma, and there is a moderate association between the presence of oxidative stress and the development of sperm DNA fragmentation, and the oxidative stress can predict fertility. It was shown that it can predict a little bit fertility. And there are two methods. Either we do oxidation reduction potential or total antioxidant capacity. These are two tests. However, other studies reported little or no correlation between them, and this is one of the debates which is still present. What are facts about the DNA fragmentation? That infertile men having semen abnormalities, يعني semen with oligospermia, stratospermia, athenospermia, usually they have higher sperm DNA fragmentation compared to fertile men. And there is an association, other semen abnormalities, particularly teratospermia, strong association. And possible association between increased sperm DNA fragmentation and pregnancy outcome, whether natural or ART. Testicular sperm have lower, bardo is another fact, have lower the sperm DNA fragmentation compared to the ejaculated sperm. When to order these tests? No suggested guidelines internationally accepted, but we can ask for it in idiopathic infertility and repeated ICSI failure, recurrent pregnancy loss, or if the patient has a known cause, may suggest high sperm DNA fragmentation, like he's a heavy smoker, has a varicocele, has a marked obesity, something like this, or any general condition. What is the management of high sperm DNA fragmentation? Change of lifestyle is essential. Obesity, and control obesity and stop smoking, treat possible cause if possible, and we can give potent antioxidants. As we said from the previous lecture, that using antioxidants is not may not be effective because the little evidence that are beneficial. We can consider some sort of sperm selection techniques during ICSI, like the PEXI and the MZ, but still they are strongly doubtful that these things will help the patients. And the other thing what Wael was talking about, as we call to go for testicular sperms when we find a high DNA fragmentation. This should not be done except if we have repeated ICSI failure and we have a persistent high STDF. We don't go from the start to the testicular sperm. And the reason for this is that testicular sperm has lower DNA fragmentation compared to ejaculated sperm. And there's a trend for higher pregnancy rate and live birth rates and lower miscarriage rate with ICSI TISA compared to ICSI ejaculate. But there's no sufficient evidence to confirm all of this. It's still debatable, despite a long time of research. And there is a scheme that we have when we have a cause for like unexplained infertility or recurrent loss of IUI failure. We ask for sperm DNA fragmentation. If it is high, we can try to correct the cause if possible. If we can correct them or treat the underlying conditions, if it's still high, we can go for ICSI. We don't go for ICSI directly. If there is no high, well, this is what we do in unexplained infertility. We can usually try ICSI. If ICSI, repeated ICSI failure, we may consider the sperm, testicular sperm for ICSI. But remember that still we have a long ongoing debates about this. The first thing, that there is a significant heterogeneity between different studies, including systematic reviews and meta-analysis, and the current methods for assessing sperm DNA fragmentation do not reliably predict treatment outcomes. Effects of sperm DNA fragmentation on pregnancy in birth and miscarriage are still inconclusive 100%. There is a trend to be better, but it's not 100% conclusive, and the evidence is low. And there is a weak evidence for the predictive value of sperm DNA fragmentation testing in patients with varicocele and unexplained fertility. Yani still, bardo, it's a debatable subject. And in the guidelines, the recent guidelines of the ESHRI in 2022, this was the statement: as there is insufficient evidence for relevance of sperm DNA fragmentation test to predict a pregnancy or guide treatment decision, the routine use of this test is not recommended outside strict research protocols. This is the recommendation from the ESHRI. So what should we do? We should properly counsel the patient. When we are going to do a sperm DNA fragmentation test or consider TISA, we should talk to the patient, explain what I have said, that it's a little bit debatable, and we may use it because we don't have other options. It may improve the pregnancy rate, and that's not a conclusive thing. And we should explain these facts and debates, as I told you, and we should consider the cost, because the majority of our patients are poor, and this will have, and the ICSI procedure is not supported by insurance or by government, they pay it from their pockets, and if we increase the costs and significantly for these poor patients, it's not ethical, and we should discuss with them are they able to have an extra cost or not. And we should ensure that the test was done properly in a good lab, and we should ask about the abstinence, as I told you. And we don't rush to invasive treatments like the TISA, except we discuss with the patients this very openly. Our take-home message: the tests for DNA fragmentation may help in explaining some cases of idiopathic infertility and ART failures. Comet and tunnel assays measure actual DNA fragmentation, while halosperm measure the susceptibility to DNA damage, and Comet and tunnel are more reliable and more specific. No sufficient evidence to support any suggested treatment, or proper counseling of the patient is essential, including the cost-benefit issues. And thank you very much.
Thank you very much, Professor Ibrahim. I know time is very short. I'll just take advantage and ask a quick question. You said sometimes high DNA fragmentation is associated with congenital anomalies in babies. Any particular pattern of anomalies or no? Yeah, so general.
That's general statement, not
specific. Okay, thank you again very much. We'll move forward, and it's